Welcome to CE Conversations, a clinical podcast presented by creative educational concepts designed to improve clinician performance and optimize patient outcomes. This session, entitled Advancing Therapeutic Paradigms for Ovarian Cancer in the Era of PARP Inhibitors, a guide for the oncology nurse, is accredited for 1.5 hours of ANCC credit and is supported through an independent educational grant from GlaxoSmithKline. To earn CE credit for this activity, please visit the link in our show notes to complete the post-test and activity evaluation at the conclusion of the podcast. And with that, we'll turn it over to our expert faculty.
My name is Paula Anastasia. I am a clinical nurse specialist in GYN oncology at UCLA, and I am accompanied by these esteemed colleagues, Dr. Shannon Weston from MD Anderson and Jennifer Filippi from Mass General. Okay, so I'm going to do a quick overview of ovarian cancer. And it's interesting because ovarian cancer is not that common. The 2022 statistics, 19,800 women will be diagnosed. You think about breast cancer, 200,000. But unfortunately, over half of these women, 12,000 women, will die of their disease. For those of you in the audience that don't take care of GYN malignancies, I'm glad that you're here also, because sometimes it's like, oh, I don't care about ovarian cancer, but we're here to talk about treatments and the PARP inhibitors. And as you know, the PARP inhibitors are now in other diseases, such as breast cancer, pancreatic, prostate. So I always say, at least, even if you don't take care of this population, you probably take care of some of the other indications for this. And so you can bring that back to your practice and the side effect, and again, how you can offer clinical benefit to your patients. So I just went off on a tangent already. So ovarian cancer, the leading cause of death from gynecological malignancies. We are seeing new cases decreasing since 2008, decreased from 2.5%. I started in 1983. I know, I'm the great-grandmother up here. And at that time, my ladies with ovarian cancer, they lived about 2 years. And now I have women that, even though they're not cured, they are still alive 8-10 years later. They're still on and off treatments, and we have such great treatments, and we have you giving them good quality of life by managing their side effects. So even though we're not curing them, we are definitely prolonging their survival with all these new treatments out there. The death rate is decreasing by 2.3%, and the 5-year relative survival rate is close to 50%. And like all cancers, you know, if we can diagnose these women in an early stage, many of these women can be cured of their disease. But we also know that that's one of the biggest challenges because we don't have any effective screening tools. We do know that with genetics and identifying patients, women that are at risk because of the germline mutation, that we can potentially reduce, because we have people like Dr. Weston who can do risk-reducing surgery before these patients do have an actual cancer diagnosis. So there's a lot in there, education with our patients. Between 1975 and 2016, the 5-year survival rate for ovarian cancer increased. Survival rate increased from 33% to 48%, but unfortunately it decreased in the African American population from 41% to 44 to 41. I'm so sorry. So the overall survival decreased in the Black population. So once again, we talk about healthcare disparities, and I think it's really important that we see these numbers in front of us to realize why is this and how can we do better, and what are some of the problems and the challenges. And you look at this from Dr. Bristow, who's at UCI. He was my fellow when I was at Cedars years ago. So 53.1% of patients with ovarian cancer are treated in low volume hospitals. So those are hospitals that don't see a lot of ovarian cancer. Again, only 19,000 women are diagnosed a year. So there are some hospitals where, the surgeon may, and so a low volume physician, I always think that sounds kind of like not very nice, but so that might be a surgeon that only does surgery on somebody with ovarian cancer a couple times a year. Now, they might be a great general surgeon, but their expertise is not GYN oncology. And we know that patients are going to have a better survival, better outcome if they have their surgery by a GYN oncologist. So it's really important, and gynecology gynecologists are now being educated through all the national meetings that if you have a patient that is suspect to have an ovarian cancer, you want to refer that patient. There's enough surgery to go around for the surgeons, but you want an expert to do this. And statistics have shown that you have better survival. So we also know that race and sociodemographic status are independently associated with an increased likelihood of these patients being treated at a low volume hospital. So we need to refer these patients. I now live in a place where my academic hospital, if I were to have surgery, is several hours away. And I'm going there if I need to have a surgery for a GYN malignancy. So it's important to make sure that we have the referral base. There's lots of community and rural settings, but we don't want the surgeon in that setting. They can do chemotherapy, but I don't want that surgeon doing the surgery for an ovarian cancer. We want to refer these patients. And there's navigators, case managers, and, friends of friends that can talk to our patients about referring them to have better outcomes. So looking at the typical course of ovarian cancer. So we know that sadly, because there's no effective screening, most of these patients are going to be diagnosed in advanced stages. Advanced is stage 2, 3, and 4, but the majority of our patients are going to be stage 3 and stage 4. We also know that ovarian cancer is very chemosensitive. Many of these patients with proper surgery and chemotherapy consisting of a platinum and a taxane, usually carboplatin and paclitaxel, will get into remission, and about 70 to 80% of these patients will get in remission. We also know with that remission comes relapse. So many of these patients will not be cured. Even though they get in remission, their cancer is going to return. Again, 75, 80% of these patients are going to have a recurrence. So then you go back to what is the treatment? We know that patients need to have optimally debulked surgery, meaning all visible disease is gone. And Dr. Weston is either going to do that up front if she thinks she can get all the disease out, or if she doesn't, she's going to give them neoadjuvant chemotherapy, about 3 cycles, and then do surgery, and she'll get it all, and then she'll give them adjuvant chemotherapy. And Dr. Weston will talk when and why, and should you also add bevacizumab to that concoction. And sometimes if your patient has a lot of ascites, stage 4 pleural effusion, we would recommend bevacizumab. But again, that's pretty dependent on the physician and the patient, and that's up for discussion. But we do know patients need to have surgery and chemotherapy. Most of these patients will get into remission, as I said. So what can we do to prevent or delay? So we're going to talk about surveillance. Do we just monitor these patients every 3 months? We'll do a CA-125, we'll do an exam, plus or minus imaging every year. Maintenance therapy. So in the old days, maintenance therapy was Taxol, which caused a lot of side effects and did not help overall survival. So now we're looking at different types of maintenance therapy, from bevacizumab to these new PARP inhibitors. But then what do we use and how do we use them? So Dr. Weston will go into that. We also know that in some situations, we still have data showing that their cancer has not returned. But for those that have a second recurrence, we're going to retreat them. And that retreatment will depend whether or not they've had a long disease-free interval from their last platinum-based therapy. And we can retreat with platinum, and patients can get back into remission. But again, that conversation, talking about goals of care with our patients, this is now a chronic disease. And that can be very devastating. And it's also very, very devastating when that cancer comes back, because patients are always hopeful that I'm going to be that N of 1 or that N of 10, and I'm going to be the one that's going to be cured. And we all want that goal up front. We also know in our management with ovarian cancer that it's very important to look at genetics. So once again, years and years ago, whenever I started nursing, I started at UCLA, and then I transferred to Cedars-Sinai. And at Cedars-Sinai, we had a large population of Ashkenazi Jewish women. And that's when I learned a lot about genetics, because almost everybody with Ashkenazi Jewish ancestry had genetic testing. Because in that culture, there were 3 identified founder mutations in the BRCA1 and 2 gene. So those were the women that were always testing. And it was just kind of like if you were young age and Jewish, you had genetic testing. And we kind of forgot about all the other people. We forgot about all the other ethnicities 60s, and we forgot about older white women. I know, that's the first, right? And so it was really interesting what we learned about through genetics, and still learning, but we know that up to 40% of patients with a BRCA positive or associated mutation have no family history. We also know with the BRCA1 mutations, it affects a younger age, and there's more people at risk, more people, well, both men and women, but only the women are going to get the ovarian cancer. And we know with the BRCA2, it tends to be later onset and not as prevalent. And we also know the average age of ovarian cancer is in the mid-50s, and we know as we get older, we're at risk for cancer, 50s, 60s is when we generally see it. And so a BRCA2 mutation, the onset might not be until late 50s or early 60s, as opposed to the BRCA1. So we talk about genetics, and you'll hear the terms germline and somatic. So germline means that that gene is inherited from either mom or dad or both in some situations, and that's at the time of conception. So that is passed down to the offspring, to every cell of the body, as opposed to somatic, which we call an acquired mutation. And that can occur for various reasons. So you think about people getting chemotherapy, that can change the DNA of the tumor. We also know there's other things, whether it's, smoking, ultraviolet light, radiation, there's other things that, we're not necessarily as absolute knowledgeable about, but we do know there's lots of factors that can change the DNA and the mutation of the tumor. So we want to be doing tumor testing as well. So looking at hereditary pathologic variants now. So we talk about mutations, and they say BRCA1 and 2 mutation, and sometimes now we change it to pathologic variant. So you'll hear that PV sometimes interchange. So looking at the most commonly, of course, is the BRCA1 and 2. The BRCA1, again, the lifetime risk 40 to 58%, as opposed to the BRCA2 is not as penetrant. We also know that there's other genes identified. That's why multi-panel testing is so important. And I think that started, I wanted to look this up and I forget because time's a blur anymore. I think since 2015, 2016. So if you have a patient that may present to you in a recurrent setting and they had genetic testing, in 2014, they may have only had a couple of genes tested. So it's really important to look at that. And sometimes patients will say, oh yeah, I had genetic testing, it was negative. I need a source document because I need to know what was tested. Now we're fortunate in an academic setting that we have genetic counselors. So if I don't have time to get that information, my genetic counselor can do the research and get that. But it's really important because we may need to do update testing. And that's really important. And that's something, again, you can share with your practitioners, talk to your patients, so we want this panel testing where we're doing, 80 different genes as opposed to 3 founder mutations, because there are other mutations in that BRCA-like scenario. So the decision point, again, all women, regardless of ancestry, so they don't have to be Jewish women, they don't have to be under the age of 50. Every single female with ovarian cancer needs to have genetic testing, and that's endorsed by all the national associations. Genetic counseling should also be offered. Now, if you're not fortunate to have a genetic counselor on site, there are also telemedicine and International Society of Genetic Counselors that can assist with this and do counseling for your patient, because it's not as simple as just doing a blood test or a saliva test. What do you do with that information? So if you don't have a genetic counselor or you don't have a really knowledgeable physician or advanced practice nurse to explain what does this mean and how do I prevent all the other cancers that I might be at risk for, including breast or melanoma, those types of things. So that's why that's really important. Somatic or tumor testing, so that's of the tumor from the ovary, should be done for patients that don't have a germline mutation. Because if they don't have a germline, they could still have a mutation in the tumor. And this is really helpful, once again, in determining treatment. So we know with these PARP inhibitors, we have niraparib, we have olaparib, we have rucaparib. And as one of my colleagues said, that's a lot of ribs going on there. We need to know which one are we going to prescribe, and how beneficial will this be? I don't think we've quite determined who's going to have, we know that patients with the mutation should have a benefit, but not everybody follows the textbook. So we do have patients that everything looks perfect. They have a mutation. They're platinum sensitive. They've had a good response. These patients should do well and respond, but not always. And we also know that patients that don't have a mutation may also respond. So it's, I think part of the mystery and the puzzle and the research is, how do we determine who's going to respond and who's not? So we also look at homologous recombinant deficiency. So that's a deficiency or a mutation in the pathway for DNA repair. So when we look at DNA repair, we're checking the tumor because you'll hear HRD. So human recombinant deficiency, which interferes with DNA repair. If the patient's tumor identifies that this patient has a deficiency, we call them HRD, homologous recombinant deficiency positive. So those patients most likely are going to respond or have a clinical benefit to a PARP inhibitor. So there's a lot of different genes associated with it. So of course, I'm out of time, so let me go through this real quickly. You have a 59-year-old Hispanic female with no known family history of breast or ovarian cancer. She's diagnosed with stage 3C high-grade ovarian cancer. She undergoes optimally debulking surgery and receive carboplatin and paclitaxel for 6 cycles. Do you offer germline testing, somatic, or both? When would you initiate the conversation? So Dr. Weston, could you address that?
I think lots of institutions do this differently. I think you have made an excellent case that we should be doing this testing on all our patients with high-grade epithelial cancers. What we do at MD Anderson is a sequential bit of testing where we start with the germline multi-gene panel testing. And then if that is negative, then that triggers subsequent somatic testing as well as testing for homologous recombination deficiency. And for us, if we obtain the germline testing and it's positive, we kind of stop there a lot of times because we've got our answer, we've got the most important bit of information. I will say there are institutions that'll do the somatic first or just do somatic, and I would just caution you because we will miss about 5% or so of germline mutations that don't show up in that tumor testing. And obviously, in addition to the treatment paradigms that we're going to talk about in just a minute, it also matters for the family where you want to do that cascade testing or testing of all family members and making sure that maybe you can prevent a future cancer, as Paula mentioned. So it's really important to make sure that you understand that germline piece very well. And I'll let you answer more.
Yeah, I was just going to say, I think, to answer the when you initiate the conversation piece right away, because not only does it inform treatment decisions down the line, it can kind of inform prognosis too. So you have, a little more information for your patient, and then of course their families are going to want to know, so they can get tested too if there is a positive germline result.
And the germline testing takes a little while, right? We don't get it back right away. Often it's 3 to 4 weeks, that type of thing. And so getting that information and not having to urgently kind of, push to get the information to make those maintenance decisions is really critical.
And when you do germline, do you do it when they're newly diagnosed, or do you do it when they're finished therapy, or does it vary?
We do it upon diagnosis. And in fact, we've got some trials that involve neoadjuvant treatment with PARP inhibitors. And so we're doing it rapid even before we, get a complete diagnosis to try to see if a patient can qualify for those treatments. And so we've really started it early. It's part of my new patient visit now.
Mm-hmm. Yep, same at MGH.
And a question just came in about panel testing. So when you're ordering your genetic testing, how many panel would you do? And there's different companies, and we're not going to endorse one over the other, but about on average, what number of panel would you order?
Yeah, I think for us, I think the panels that we use have about 26 genes, and they cover a lot of the genes that Paula mentioned. In addition, so you've got that BRCA, of course, 1 and 2, but then looking at the Lynch genes and then other more rare homologous recombination deficiency genes that can be potentially important either from response to PARP inhibitors or just for hereditary cancer risk.
We have a kind of a cool thing going on. Our genetic counselors provide an iPad to our patients upon diagnosis, and they can kind of read through everything by themselves before the clinician comes in and kind of get a good idea of what sort of panel testing do they want none? Do they want just the bare minimum? Do they want the full testing? So that's kind of an interesting way to do it. And then of course, if they do need a genetic counselor or they need more discussion about it, they can see a genetic counselor at that time. But I think it's a good way to get people in and informed really easily and quickly.
And then just because somebody asked this question and we're talking about genetics, so sometimes you'll see when the report comes back, it'll say BRCA1 or RAD51 pathologic variant. So that means they are positive. Sometimes you'll see a confusing one, it'll be variant of unknown significance, VUS. And at that time, it's not pathologic, so you don't do anything with it. But we let them know that the genetic company will update the genetic counselor or the ordering practitioner and update them. So that was one of the questions that, yes, it could be 2 years later and we find out that this has been identified. This is a rare VUS, but now it is pathologic. And we will inform the patient and make different treatment decisions based on that. So it's very important. So treatment decisions, so genetic testing up front. Again, you want to do it in that course of their diagnosis before they finish treatment, because we know that maintenance therapy will impact this. So whether your patient's getting neoadjuvant or upfront surgery, they're going to have both, and then adjuvant therapy and maintenance therapy. So I want to turn this over to Dr. Weston, who is going to talk us through all the data and the treatments and when to prescribe. Thank you so much.
Thank you. Hi, everybody. Welcome. So, a little early, but I think you guys are looking pretty perky and we're getting questions in, so that's a good sign. So I'm going to take the next 15, 20 minutes or so to talk a little bit about some of the data that is informing our use of PARP inhibitors or the patient in front of us in clinic. And this is just a snapshot, Paula already alluded to this, of where we're starting to see these PARP inhibitors used. And obviously this is a talk focused on ovarian cancer, but we are seeing approvals in breast, pancreatic, prostate cancer, and I expect more and more. I think what we're seeing across targeted therapies is a more molecularly based selection, where we're moving away from, say, okay, this is only for patients with pancreatic cancer, this is only for patients with ovarian cancer, and instead looking at this is for patients that have this mutation. And so I suspect we'll continue to see more and more use of PARP inhibitors across all advanced solid tumors. And this is for your reference. I think you guys get these slides. And really just shows you the expanse of where PARP inhibitors are indicated in ovarian cancer. You can see we have 3 drugs currently indicated in ovarian cancer: niraparib, olaparib, and rucaparib. And all of those have both a treatment indication, which is when we have disease and we're trying to shrink it, and they all have maintenance indications, okay? So niraparib and olaparib have maintenance indications both in frontline as well as second-line ovarian cancer, and rucaparib currently has an indication in second-line. So let's talk a little bit, if we've got all these PARP inhibitors indicated in the same place, we're gonna look at the efficacy data, but to coin a phrase that Paula just used, spoiler alert, they all look the same. So from an efficacy standpoint, they all seem to work very well. They hit their target and they do their job. So how do we determine which one we give to the patient in front of us? How do we determine? So of course, the indication, right? We stick to our FDA labels, sort of, sometimes, most of the time, but we do, try to give the drug to a patient population that already has that approval. We're going to use our molecular testing that Paula just described, not only that germline testing, but also somatic testing and HRD. We'll look at the toxicities. What are the toxicities that the particular drug causes? And there are class effects, for sure, but there are some unique toxicities that Jennifer's going to review with you that may help you with the patient in front of you. If they already have a pre-existing issue, you may not want to exacerbate it with one of these drugs. We look at drug-drug interactions. We have a lot of patients in front of us that have polypharmacy. They've got a ton, they're on a ton of medications, and we want to make sure that the new drug we're adding isn't going to interact negatively. What's the schedule, right? How often do you have to take the drug? The price matters, and does her particular insurance company give less of a copay with one of the drugs or the other drugs? So these are important things that we have to consider. And then of course there's some special clinical situations that we can consider as well. Okay, so principles of maintenance therapy. This again, I'm not going to spend too much time on this table. It is packed with information, and it's meant more as a reference for you. Again, understanding upfront and second line maintenance. Where is the indication? What is the dose and administration? And then how long? But I think what I want to call your attention to here is it's not all the same, right? So in upfront maintenance, we're generally going to stop maintenance. We're not going to continue it to progression, okay? So for olaparib, we're going to only do 2 years. For niraparib, we can do 3 years. And then in recurrence, in second line, you're going to generally be able to continue that drug until progression, or of course, if there's a toxicity or some other reason why the patient can't continue the medication. Another snapshot, okay, filled with information meant as a reference, but is just to kind of show you in one slide all of the survival results from the kind of big 3 upfront maintenance studies that have been presented to date. The PRIMA study looking at niraparib, the SOLO-1 study looking at olaparib, and the PAOLA-1 study, which combined olaparib with bevacizumab. And what I want to just kind of summarize about this table is they all work, okay? They all work. It depends on the population they were looking at, but they all work for patients with upfront. What we start teasing out is the molecular subtypes. And so, as Paula already mentioned, BRCA mutant has the best benefit. Patients with any type of BRCA mutation, whether that is germline or somatic in the tumor, seem to get the most benefit from a PARP inhibitor. HRD, kind of next best, still very good, still a really nice improvement in survival, but a little bit of a step down. And then those patients that have no biomarker, that are BRCA wild type and HRD proficient or HRD negative, those patients have the least amount of benefit, but still can get some. Now, and that may be because we don't completely understand the way the drugs work. It may be because our tests aren't perfect, right? We're testing a patient and her tumor is deemed homologous recombination proficient, and yet she still gets benefit. So I think that's some of the kind of stuff we just don't completely understand.
What's proficient?
That is HRD negative, right? So, but they're trying to move away from the terminology of HRD positive, HRD negative, because it gets kind of confusing. So HRD is homologous recombination deficient. They have one of the abnormalities that should predict benefit from a PARP inhibitor, and then HR proficient, homologous recombination proficient, is that negative group. They don't have that biomarker.
And then wild type.
Well, wild type is more related to germline, right? So you've got...
But I think that they don't necessarily know those terms sometimes.
Right, so germline, so you are either mutant or wild type, right? And then that's one part. And then you look at the HRD test, which is a completely separate test. Most of the time, if you have a mutation, you're HRD, right? You've got homologous recombination deficiency, but not always. The tests aren't perfect. So mutation trumps always. If there's a mutation, like I said before, sometimes we don't even check for HRD because I'm like, that's only going to confuse me. If I see something different, if I've got a mutation, I'm treating that mutation, period. Okay. If I don't have a mutation, then I'm going to look for that HRD and understand what that means. Does that make sense? Okay. All right. So I'm going to talk a little bit about more of the data. So we saw kind of the overview, that overarching with, yes, there's survival benefit for all of these, but let's kind of tease out what's different about each of these trials. Okay. So the SOLO-1 trial was an upfront maintenance trial. So all the patients had newly diagnosed high-grade ovarian cancer, either serous or endometrioid. They had a benefit from their chemo. So you'll see CR, PR, that means complete response or partial response to their upfront chemotherapy. This is critical. This patient population all had mutation, okay? They all had a germline mutation, and they allowed for somatic mutations, but I think on this particular trial, there was only like 2 patients that had a somatic mutation. But what we know is germline and somatic mutations in regards to response to PARP are the same. Okay, so you don't have to tease that out. They have a mutation, they get the PARP, okay? So they were randomized 2-to-1 to either olaparib monotherapy for 2 years, as I mentioned, or placebo. And the primary endpoint was progression-free survival. So how long did it take for their cancer to come back? Now, I'm sure you guys have seen Kaplan-Meier curves before, but I'm going to teach you about it because I always like the way my instructors taught me. So, we've got time along the bottom, and then we've got proportion surviving along the left side. You want basically a perfect drug would be straight line across the top, right? Nobody progresses, everybody lives, yay. But that's not real life. So, so then you look at the difference between your two lines. Your top line is your intervention, we hope, if it does better, right? Your bottom line is standard of care, right? So the bottom line is placebo. You want a big space in between, right? And my instructor always used to say, do the thumb test. Can you fit your thumb between the curves? Like this is like a Mack truck, right? You could drive like a truck through this. So these curves, you don't need to look at the numbers. You can tell that drug works to extend life. The other thing I want to call your attention to is the 2-year time point, right? We stopped the drug at 24 months. Can you see that 24? I know there's a lot of information on the slide, but that continues to work beyond. And this is critical when you're counseling your patients. And that's why I wanted to call your attention to it. Because most patients are going to say, should I really stop? Shouldn't I just keep going? I feel fine. And you can tell them, no, your curve is going to look good. You've gotten your benefit, stop the drug, because as Jennifer is going to talk about, there's some really, rare but very serious adverse events that can happen from these drugs with long-term use. And so you don't want to keep your patient on this if you don't think you're going to get more survival benefit, and you could potentially cause more harm. So PRIMA, so Solo 1 was all BRCA. PRIMA is an all comers, okay? So again, upfront, had benefit from their treatment, and then were randomized to niraparib or placebo. Now, the difference in PRIMA is they teased out a little bit more of a high-risk population. So they included patients that had stage 4 disease or had residual disease at the end of their cytoreduction, so suboptimal tumor reductive surgery, okay? And those patients had a 2-to-1 randomization, okay, between niraparib and placebo. And again, we were looking at progression-free survival. And I should mention, all these studies also looked at overall survival, but it's too soon, okay? Hopefully it'll be too soon for a while because the patients are living for so long. So we're anticipating that this benefit in progression-free survival is going to yield long-term overall survival, but we don't know yet, okay? So this is the curve from what's called the intention to treat, okay? So this, again, it included all comers. It didn't select out just by patients with BRCA mutation. So in the all comers, as far as biomarkers concerned, there was a benefit. There was a reduction in the risk of progression of about 40%, okay? So this got an FDA approval in all comers. But I think Paula taught you, and I hope I've taught you a little bit, the biomarkers matter, right? So we do see a difference in the response or the benefit based on the biomarker. So if you look, on the left is the group that's housed under that homologous recombination deficiency. And to Paula's point, that includes the BRCA mutant group all the way on your left, and the HRD BRCA wild type, so no mutation, but had that homologous recombination deficiency. You can see, use your thumb test, that's positive, right? That's the MAC, really, it's a MAC truck for the BRCA group, right? About a 60% reduction in the risk of progression. And about a 50% reduction in the HRD group. Now you may be saying, Shannon, it doesn't look quite as good as Solo 1, and I'd say not so fast. We do not cross-compare trials because they're different populations. And I told you, this is a more high-risk group. I would argue everyone with ovarian cancer is high risk. So let me just put that out there. But they teased out that patient population that had stage 4. They teased out that population that had residual disease, things that we know impact prognosis. And so that's probably why we don't see as big of a difference or as good of survival between the two, but that does not mean that this drug's any different than olaparib, okay? And then finally, when you look at that homologous recombination proficient group, right? There's still a difference, right? There's about a 32% reduction in the risk of progression, but it's not as profound. To me, that tells me that group has the worst prognosis. And there may be some people in that group that benefit that we just don't know who it is, okay? But it's worth a try in a patient that says, I want to do something, So this is really where shared medical decision-making comes in, where you tell a patient, well, it's not a slam dunk for you, but if you want to do something, this is an option for maintenance rather than doing surveillance. Oh, okay. So PAOLA-1 was the third of the big three upfront studies. So this was a population of patients, again, newly diagnosed, advanced stage. They had gotten their chemo, but here's the difference. They all had gotten bevacizumab with their chemo before the trial. So for the reasons Paula was mentioning before, their surgeon, their medical oncologist decided to give it to them. That may be that they do it for everybody, because we know that the addition of bevacizumab improves progression-free survival. But there are those of us that kind of tease out the population we think benefits the most. People with stage 4 disease, people with bulky abdominal disease, lots of fluid, ascites, pleural effusions, that we know that bevacizumab can help dry up. So that decision happened, okay? They were already on chemo with Bev, and then they were randomized 2-to-1 to either receive olaparib with the bevacizumab or the bevacizumab alone. So this is different from the other trials we had, because we have an active comparator, right? We don't have just a pure placebo here. They're getting an active drug. And this, again, was looking at progression-free survival, and in the intention to treat group, so the all-comers group, there was a benefit. There was a reduction in the risk of progression of about 40%. But I know what I know you know what's next. The biomarkers, right? Because I'm gonna show you the biomarkers. And again, just like we saw in PRIMA, HRD positive, including the BRCA mutation group, did the best. Look at those curves. Wow. Those curves are bonkers, right? That's even bigger than the SOLO-1 curves. And I know I'm not supposed to do that, but I did it anyway. But like, this is a nice benefit for our patients with BRCA mutation, right? We move to the middle, HRD positive, right? Homologous recombination deficient. Also really, really nice benefit. And then look at that HRD proficient group, that HRD negative group. Yikes, no difference, right? Now, interestingly, this was an exploratory analysis. This study was not powered by stats to look at that comparison, but the FDA did. And they said, you know what? The indication is for HRD. So for this combination, it's for patients that either have a BRCA mutation, germline or somatic, or homologous recombination deficiency testing positive, okay? So that's who we have an FDA indication for the combination of BEV and PARP. Oop, look at me, okay. All right, so I'm gonna cruise through these data because they're a little bit more, you've probably seen them before if you've come to one of these studies, but this is looking at second line maintenance. So this is, we're kind of going backwards in time. When we started drug development with PARP inhibitors, we actually started with treatment, then we went to second line maintenance, and then front line. But the talk doesn't make sense like that. So we gotta talk about the way we see the patient in front of us. So we talked about front line. As we give more and more PARP inhibitors in the front line, these studies may become less and less relevant, but it's still important for the patient in front of you who's not yet been exposed to a PARP inhibitor. So the SOLO-2 trial was olaparib as a single agent, again in a population that had recurrent platinum-sensitive disease, had their chemo, got their benefit, and then were randomized to either the PARP or the placebo. These patients all had a BRCA mutation, okay? So it's similar to what we saw with SOLO-1. And what do you guys think? Is this positive? Oh yeah, oh yeah. So a nice reduction in the risk of progression, 70% reduction in the risk of progression. So really exciting data that led to an FDA approval for olaparib. The NOVA study, similar. They had actually, it was interesting, they did it in 2 cohorts. They had a cohort of patients with BRCA mutations, and then they had a cohort of patients without. And they, again, platinum sensitive, response to therapy, got randomized to either niraparib or placebo, looking at progression-free survival, and you can see the 2 curves. So the top curve has the patients with a BRCA mutation, clearly very, very positive, very, very good. And then the bottom part has the patients with BRCA wild type. Now that included patients that had HRD as well as HRP, okay? So homologous recombination deficiency positive and negative were included, and they did tease that out in further studies. Because, I'm gonna show this to you every time. You guys are, and you're probably thinking it's like second verse, same as the first, but I want you to think that's good because it's consistent, right? You're seeing consistent results. That makes you feel very confident that these actually are true, okay? So best results in patients with somatic BRCA mutation, right? It's just like germline. Okay, better results in HRD positive, but wild type, no mutation. And then the least amount of benefit, but still some benefit, just like we saw in PRIMA, for the patients with homologous recombination deficiency negative, okay? Then finally, Ariel 3 rucaparib, okay? Same population, high grade, had benefit from their platinum, randomized after response to treatment to rucaparib or placebo. They teased out the mutations. They did a really good job statistically, and consistent results, okay? BRCA mutant, homologous recombination deficient, and then the whole group, the group as a whole, and the intention to treat had a benefit. But when you tease out that totally negative group, you start to get less. Okay, finally, treatment. This is going to become more and more rare for our patients, right? Because as we're pushing these PARP inhibitors into frontline maintenance, into even second-line maintenance, the use of it as a pure treatment is going to change, okay? But the bottom line is these studies that I'm going to show you are the reason why we moved it frontline, because we saw great benefit for patients with a BRCA mutation when they were treated with a PARP inhibitor as compared to chemotherapy, okay? So SOLO3, I bet you know what drug it is, right? Because you've been paying attention, it's olaparib, right? So this was a confirmatory trial. This drug had already gotten an FDA approval based on single-arm data, right? This was so exciting for us in ovarian cancer. We got an approval for a 33% response rate in a single-arm study. So it got accelerated approval from the FDA, but this was the confirmatory trial, okay? So patients had recurrent ovarian cancer, more than 2 lines of platinum. They could be platinum sensitive, okay? Now, one of the beefs with this trial is it was randomized to olaparib or a non-platinum, which most of us kind of shook our tiny fists in the air and said, I would never do that. If I have a patient with platinum-sensitive disease, I'm going to give her a platinum. So there was a little bit of grumping about this trial and the way it was designed, but they could get weekly paclitaxel, topotecan, pegylated liposomal doxorubicin, and gemcitabine, okay? And this was Dr. Richard Penson presented these data, and they were so exciting, okay? Because it was better. PARP outperformed chemotherapy, okay? And if you look at kind of the data I'm showing you, the top left boxes are response rates. So does the tumor shrink? That's what that ORR is. That includes CRs, complete responses, and PRs, partial responses. And this was exciting because a lot of people were thinking of these targeted therapies, sometimes they just stabilize the disease. So are we really going to see a better response as compared to chemo? And the answer was yes, and that was across multiple lines of therapy. And you can see these waterfall plots on the bottom. That's how much did it shrink. You want to see all falling. Look at that, all of that. So many patients got some shrinkage, maybe not even qualifying as a response, but still had benefit. And then of course, on the right is our progression-free survival. Now this needs the thumb test, but it works. The thumb test works. So it did improve progression-free survival. So Ariel 2 was rucaparib, okay? So this was a single-arm study, more than 2 prior lines, where they showed better response and better progression-free survival in patients with BRCA mutant ovarian cancer. And that got an FDA approval. That was our accelerated approval. And then they did Ariel 4, which was our confirmatory randomized trial to rucaparib versus standard of care. And they could continue it as long as it worked. And they've only presented their PFS data. Is it positive? Yeah, put our thumb, yeah. So it's better than chemo. And I would argue you don't have to be better than chemo, because if you have better side effect profile and you don't have to be on chemo, but it outperformed chemo, and so that was a successful trial. And then finally, Quadra is the study that led to the approval, the accelerated approval of niraparib. This is a single-arm study. They looked at all population of BRCA or HRD, and they looked at response. So is this a good waterfall plot? Pretty darn good, yeah. You know, I just want to call your attention. The blue lines are patients with a BRCA mutation. The orange are patients just with HRD. So you can see, even though they didn't have that mutation, they still got a benefit. And so that yielded an FDA approval, and there's a confirmatory trial ongoing. So what's next? I'm going to take just a hot second. We're doing lots of combinations to try to overcome that resistance that Paul was saying. People don't follow the textbook, and sometimes they have a BRCA mutation and they don't get benefit, or they have HRD and they don't get benefit, or they get some benefit and then ultimately have progressive disease. And so there's a lot of studies looking at how we can combine agents to get better results. The Imagine 50 study was taking Bev plus atezolizumab, which is an IO, an immune checkpoint inhibitor. Unfortunately, it was negative. So there was no PARP in this study, but I felt like it was important to show you that was not enough. The combination of Bev and immune didn't improve over Bev alone. And there's a number of upfront studies that are super exciting that are going to hopefully answer PARP combinations. So the Athena study, getting presented at ASCO in a month, is looking at rucaparib, the PARP inhibitor, versus nivolumab, an immune checkpoint, versus the combination, okay? This is upfront maintenance, just like SOLO-1, PRIMA, and PAOLA-1, but looking at a novel combination. The first trial is taking niraparib plus Bev plus dostarlimab, which is TSR-042, which is a PD-1 inhibitor, a checkpoint inhibitor. And then there's two different olaparib studies, one looking at durvalumab, the checkpoint inhibitor, and bevacizumab. You can see it's kind of like a theme. Everyone's trying to get all their drugs in the upfront. Or one is looking at the Keylink 001 is looking at pembrolizumab and olaparib, okay? So we're gonna have to come back in a couple of years when all these studies report and see where are we now? Are we giving all of our drugs up front or what? All right, well, I'm gonna turn it over to Jennifer to talk about how we give these and the adverse events that we might see.
Thank you so much, Shannon. That was excellent. All right, so we talked about sort of the decision tree of upfront treatment and who gets what in the maintenance setting. We talked about why, all the trials, and now let's concentrate the rest of the time on the patient, the bread and butter of what we do as oncology nurses. So I won't go through this. I just made this. I thought it was an easy sort of way to look at it, but you guys can have that for your reference. So this is just an overview of the most common toxicities. I'll talk about each of them in the next slides. As you can see from this slide, the discontinuation rate of PARP inhibitors is relatively low, 11, 15%, and then when combined with bevacizumab, you get up to 20%, but that's still pretty good. So this is just telling us that overall, they're tolerated pretty well, and we've gotten pretty good at controlling these toxicities and working with the patient, dose reducing when we need to. So let's just talk about kind of the separation between the non-heme and the heme toxicities. We'll start out with non-hematologic toxicities. All grades, it looks a little bit messy. It seems like there's a lot of toxicities with these drugs, but they're all, in general, pretty mild and controllable with dose holds, dose reductions, and different mitigation techniques. Grade 3, pretty rare. So usually we do see toxicity, but usually it's grade 1 or grade 2, and we can kind of help them through. So I just want to remind you all that PARP inhibitors are still moderate to highly emetic drugs. Over 30% of patients are going to see some nausea. I don't see too much vomiting, but certainly nausea, poor appetite, queasiness, that sort of thing. So the good news is usually this improves within 4 to 6 weeks of starting the PARP inhibitor. So usually what I'll do is recommend a prophylaxis to start, and then people tend to feel a little bit better as they go on. They forget to take their ondansetron, or I really like olanzapine at night. It helps them sleep, helps prevent nausea. And then after 4 to 6 weeks, they usually feel better. Now, certainly there are patients that do have persistent nausea or severe, vomiting, and they could lose weight and whatnot. At that time, probably we're looking at a dose reduction. But in general, people do pretty well with this. Fatigue is one of the hardest side effects, I think, to deal with. It's multifactorial. People are just coming off their upfront treatment. They could be anemic. Important to look at different reasons for anemia, so doing a panel on folate, B12, iron testing, just to make sure there's no deficiency we can correct, maintaining good nutrition, staying well hydrated, all these things. Physical activity, our patients are deconditioned from upfront therapy, so just kind of getting moving again, and this can help with sleep as well. There are some psychosocial interventions like cognitive behavioral therapy you could try. And then I want to mention niraparib can cause insomnia, so if that patient has this new insomnia, if they're taking the niraparib at night, you could try dosing it in the morning, sometimes that works, or dose reducing, or maybe even switching the PARP if it becomes really bad. And like I said, there's always room for dose holds, dose reductions. You can use stimulants. I don't love them, but they're there for certain people. So switching gears into the hematologic toxicities, again, you'll see all grades. It's a 20 to almost 60% get anemia, neutropenia, thrombocytopenia. And I just want to point out on this slide that you'll see with niraparib a higher incidence of these things, and especially the thrombocytopenia, all grades and grade 3 and greater. And we'll talk about that. So with anemia, this one is usually pretty easy to manage. You can give them blood transfusions. In our clinic, we usually offer for a hemoglobin less than 8, but there's no hard and fast rule. This is an art as well as a science, right? So you can always hold the PARP inhibitor if you feel like you need to, but I don't think that's always necessary, and I'll go into some case examples of why. For platelets, niraparib, you want to check weekly upon starting. So 4 weeks in a row, they have to come to clinic or go to their local lab and get tested. Their CBC needs to be tested. And if they do have platelet drops, which we do see, and they can be significant, I'm talking about, like, I've seen patients with normal platelets and 2 weeks later they're 20. So you have to pay real close attention to that. And at that point, I would hold the drug, probably offer a dose reduction once they recover. Neutropenia, the same with IV chemo. If their neutrophils are less than 1, probably want to hold, consider a dose reduction. But sometimes, interestingly, it helps if you hold the dose, and then you can actually sometimes restart it at the same dose and see how they do and kind of monitor that way. Usually I just go by how serious or how significant the blood count is. But do know that you can try again to restart on that same dose if you're willing to take that risk. All right, so the 2 cases about anemia. The first patient, young, fit, 50s, BRCA1 mutation. She was on niraparib about 12 months. She is a woman who goes snowshoeing, skiing, all the winter stuff that people in Boston do. So she's very fit. She called me and she's like, I was trying to walk up my stairs and I felt short of breath. So, that was very strange for her, brought her right into clinic. Her hemoglobin was 6. So this is a situation where I definitely wanted to hold the drug, get her a transfusion right away, and then we restarted with the dose reduction just because of how significant it was, I think. Patient 2, I managed a little bit differently. She was on olaparib bev following upfront treatment, HRD positive. She was on for about 4 months, and post her upfront treatment, her hemoglobin never fully recovered. So this is kind of like a more gradual, slow dip in hemoglobin for her. So for her, I didn't really hold the drug. I think maybe I did a day or 2, got her transfusion in, and then I restarted her at the same dose, just because it was more gradual. She wasn't very symptomatic, and she's done fine ever since. She hasn't needed another transfusion. She's been good on that same dose. So just to kind of show the different management techniques, not everything's black and white. We need to talk about MDS. The incidence is very rare, but it certainly can happen, and especially talking about all these heme toxicities you're following, if you're not seeing recovery of those counts within a couple weeks, that's a referral to hematology oncology. I've definitely seen this in practice, and I think these 2 have as well. It is rare, but it does happen. It's something we need to be vigilant about. There are some agent-specific adverse events. I'll just go through these kind of quickly. Hypertension with niraparib happens about just under 20% of the time. So you do want to monitor blood pressure on these patients. I usually just do it when they're in for clinic, or if they're high risk, you can get them a blood pressure cuff for home. But I've definitely seen this. Usually it's easy to control with one antihypertensive. Posterior reversible encephalopathy syndrome, or PRES. I've personally never seen it, but it sounds super scary, and it has happened. So just to be aware, obviously if your patient's having seizures or mental status changes, you're sending them to the ER, but just know that it has been reported with that drug. Pneumonitis with olaparib, another quirk of olaparib. Again, exceedingly rare. I actually have seen a mild case of this in clinic. This particular patient, we were able to keep her on. She just had radiographic evidence of her pneumonitis, but was not symptomatic at all. Of course, if she became symptomatic in any way, we would stop the drug and treat her accordingly. But again, something just to be aware of. Something to note about niraparib is that the starting dose is 300 milligrams once a day, but a lot of our patients will not get this starting dose because there's something we like to call weights and plates. So if a patient is weighing less than 170 pounds or their platelets are less than 150 when they start, that's an automatic upfront dose reduction to 200 milligrams a day. And I would say this is most of our patients. I don't know, I'm like barely starting anyone at 300. So anyway, that's just something to be aware of with the niraparib. And it's once daily. The other two are twice a day. I will not go through these in the interest of time. So just to go over some key counseling points when starting people on oral chemo or PARP inhibitors, oral chemo is still chemo. Remember that. People, they want to be done with their treatment. They want to go back to their lives, back to taking care of their grandkids, their children, going on vacations, all these things. So even without maintenance therapy, I'm always telling people, it's going to be a good 3 to 6 months before you start to feel like yourself. And now we're adding more chemo. It's oral, but it's still chemo. So just like IV chemo, sometimes it takes a while to get to the right dose for your body and an acceptable toxicity level. So you really have to be available for your patients and work with them to figure out what works best for them. And like I said earlier, still moderate to highly emetic. So starting them out on a olanzapine regimen or on danzatron before, you can take with food. They shouldn't be vomiting, so if they are, they should call you. And we should expect some level of fatigue on these. You're not gonna feel 100% normal. And if you're not able to perform daily tasks, go back to work, do the things you love, we do consider a dose reduction at the time. And I've absolutely done dose reductions for fatigue and with good success. I think now we're going to move on to a challenging case. So I'll just kind of go through, this is one of my patients, and then maybe we can open it up between the three of us to talk about kind of unpack it. So this is a woman with ovarian cancer. She's 72. She's Black. She lives alone in low-income housing. Very limited support system. She has this niece that sometimes helps out. She has a church group she's with quite frequently, but she often tells me she doesn't want to be a burden. So it's okay. I just didn't know what you were doing.
Talking to me.
So she doesn't want to be a burden like most of our patients. So she doesn't want to rely on other people. Her insurance, we were trying to get her on a PARP inhibitor. Her insurance was a large copay. Eventually able to obtain copay assistance through the pharmaceutical company, which we're so grateful for. Her performance status was about a 2, I'd say. She was relatively frail, but could kind of get by. She still did live on her own. She actually did have really good compliance taking the pills, taking her PARP inhibitor, I thought, but she was really hard to reach by phone. And with niraparib, like I said, especially when you're first starting it, you want to be in constant contact with your patients. So I used to call her on Thursday afternoons during my admin time, and she would never answer. So it became frustrating. Eventually, when she came back into clinic, I'm like, hey, you got to answer my phone calls. She's like, well, I have church Thursday afternoons. So she was never going to answer her phone on Thursday afternoons. So just, I think sometimes we get caught up in our clinic and these people should be available when you want them to be, but they're people, so you have to work with them. She did have some hypertension. That was a mess. She couldn't afford a blood pressure cuff. I found one in the clinic. I kind of scrounged up for her, sent it to her house. We worked through it on the phone. She couldn't get it to work. Coming to clinic was a hardship for her. Eventually got her there. We taught her how to use it. That was good. I think at one point she had a UTI. She couldn't get to the pharmacy. Finally did, and then she couldn't open her pill bottle. So just a lot to unpack with this case, a lot of hardships to uncover. But eventually we found our groove. I call her, every other week now, not on a Thursday afternoon. And we got her a VNA, which she was at first pretty resistant to. And she had life alert, home safety evaluation, all that. So I think we're in a good place, but it was definitely challenging to start her on the PARP inhibitor and get through those first 4 to 8 weeks. And I think now, if either of you want to kind of comment, I don't know if you've had patients that have required copay assistance or some of these same sort of challenges with starting people. Any comments or questions about the case?
I was talking to Jennifer yesterday or the other day, and I was talking to her about real life challenges, and I love this case because it's not just like you're prescribing an oral medicine and it gets shipped to their home. There's so many things with, overusing that word, financial toxicities, and, the barriers and the challenges that people undergo. And, kudos to you for being so vigilant to follow through and really take care of this person. And I was saying that, there are places that are understaffed, and, the diligence of the nurse, and not everybody has a navigator or somebody that's, got a great work ethic. And I think that, this is really challenging. If we have social workers, if we have case managers, anything we can do to provide extra help. Financial toxicity in California is huge. I mean, I literally have had patients that have had a $12,000 copay for a PARP inhibitor to nothing. I mean, it's ridiculous. I am always asking for resources. So I will go to my pharma representative, and I don't think we utilize them enough. And the copay assistance with the companies and calling them and asking for help and assistance. Some of them will provide free drug upfront until we can better find a better pricing guideline. But I think it's really important to use those resources that some of our pharmaceutical industries will offer us. And it's like, they're not allowed in the office and that sort of thing. But even when you're going to the exhibits, they really can help because they want to help the patients as well. But I really appreciate just recognizing what a challenge this is for our patients and the financial burden.
Yeah, I mean, and I think it's exactly what Jennifer was saying. Like, one, you have to really incorporate your counseling up front to make sure that the patient understands what she's about to go through, because it is, a lot of them are like, oh yeah, I'm going on a pill. And especially if they have friends that have breast cancer, those pills, like anti-hormone pills, they're generally a lot easier to tolerate. And people do feel like they're completely off chemotherapy, and really making sure you jump out in front and there's not any mixed messaging, and that the patient knows we need frequent check-ins. And if you do develop these symptoms, we can handle them. I don't want you to be out there by yourself feeling terrible, stop taking your medication, or potentially lose the opportunity to get the benefit from this medication. So that was something that I think when she was talking about not just this case, but also through her talk, it was really resonating for me, because I feel like the early dose pauses, the early dose reductions are good for our patients to be able to find that sweet spot dosing. Because, we're treating these pills just like we treat every chemotherapy. Oh, the max dose must be the best dose. I don't know that that's not necessarily the truth. That's what we do. But a lot of these patients will do fine on a reduced dose, will still get that benefit, and will feel much better. And then you won't lose that potential opportunity to get that patient survival benefit. So I think, early counseling is really important, because not all of us have the resources to call as much as we can. I mean, I'm in a position where we are very fortunate, and we do. But if you don't, that upfront counseling can really help your patient feel empowered to call you when she starts to have, different symptoms. And so you can intervene early rather than trying to play catch up.
And kind of along that line, there's a question here that says, what's the average commute for your patient? In upstate New York, it's about 1.5 to 3 hours, making follow-up, rapid intervention, and transportation barriers of care. Well, when my previous place, I lived 8 miles from work, and it would take me 45 minutes to an hour. But yes, we have patients in LA that it can be a 2-hour commute. So having said that, how many of you use telemedicine, especially when you're starting your patient on an oral medicine and they can do local labs, fax them to us, email them to us, and then we can follow up either by telemedicine or phone call. Do you utilize that in your practice?
Absolutely. Yeah. I think that's like one of the good things that came out of COVID is it's a different era of telemedicine, and it's so easy for the patients. They love it. So yeah, that's a problem in Boston too. People spend hours in the car trying to get to us. So absolutely, it's a great option for people. Local labs are generally pretty easy to get to.
I do see this as a place where disparities are occurring though, because, to your point, we were doing this before, but it was all by phone. And so you couldn't see the patient and assess her. So the video options of telemedicine are amazing, but we still have patients, like I'm at, Ivory Tower institution, but we have patients from all over Texas and frankly out all over into rural areas of Oklahoma, Louisiana, and not all of them have access to bandwidth and high-speed Wi-Fi and stuff. And so we're often like, "Wait, are you on the computer?" And so it can be, and it's frustrating for the patient, it's frustrating for us, and so I think telemedicine has gotten a lot better, but we really have an opportunity to improve disparities by making sure everyone has access to all of these types of resources and Wi-Fi and a laptop or an iPad and things like that. So we use that quite a bit as well, but we still are finding a population of patients who can't make it into the clinic, but also are really hard to reach, through telemed. So I think that's why I hope that if you can counsel them ahead of time and they know they can reach out, then that you kind of overcome some of that. But I do like having those scheduled check-ins to make sure they know, we're here for you. This is an opportunity for you to report any issues, and you're not bothering us. Because I think we get a lot from that. "Oh, I know you're so busy." And, we're over and over telling our patients, "No, we're never too busy for you. You have to call us."
And I think that's part of the therapeutic nursing relationship.
Yeah.
That's like what we do as nurses, right? We establish this trust and we build these relationships so people don't feel like they're burdening us with their questions. I always say, never worry alone. If you're worried about something, just reach out.
That's a good line. Yeah.
I like that.
And you calling me and I can take care of something in 5 minutes versus you worrying or having a toxicity go into something serious where you need to come in or be admitted. So yes, please call us. And they're like, "I don't want to bother you." And I said, if I'm in the bathroom, I'm not going to answer the phone. But other than that, I will be answering the phone. It is okay. The other thing was with resources. Again, not everybody has the luxury of having a social worker, but I have learned from prior social workers, there are also transportation resources that we don't tap into. The American Cancer Society can supply taxi vouchers. Now, I don't think in upstate New York, if you have a 2-hour commute, they'll provide that. But there are also those transportation access services. Sometimes they're a pain because they're not always on time and all that. But there are those resources that we don't always tap into. So I think some of our patient support groups, whether we look at, one would be FORCE, there's so much out there on the internet, as if you guys have time for that, to find resources where we can help our patient for free access as well. One other question is, how long do you keep your patient on bevacizumab with olaparib if the symptoms from olaparib was treating resolve? Can you remove bevacizumab and reintroduce for symptoms?
Oh, yeah, I wouldn't do that. I think once you kind of make the investment and you're kind of made the decision to start your patient on bevacizumab, I think the question was, once like the ascites resolves or the pleural effusions resolve, can you kind of take off that bevacizumab? I generally would not, because the data that we have is for consistent use. With that being said, of course you want to monitor the adverse events, right? So if a patient is having hypertension that you can't control or headaches or something like that, and you want to take off the bevacizumab for that reason, totally fine. But what I generally would do was continue for that course. And I don't think I mentioned in the talk, but 15 cycles is generally what we utilize for bevacizumab, and then we do stop in that upfront setting.
So it's interesting because the other thing is with the oral medications, we are usually the practice nurse will be managing that. The infusion nurse won't be, right? But I have found, and again, it's like, you know, every time I make a mistake, I'm going to learn. At least I hope I do. But I think about like bevacizumab and olaparib. We've had patients where the nurse will say, oh, the ANC is only 1,200, but you know, we're just giving single agent bev, so okay to infuse. The platelets are only 90. You know, we don't usually monitor platelets with bev, okay to infuse. But you have to remember that we need to educate the infusion nurses that if these patients are on olaparib combination, at least I need to be following up with that white count. So even if we say, yeah, go ahead, I'm going to probably do another lab check in a week because I'm worried about the olaparib side effect. And I think sometimes we forget that when we're giving combination therapy. So that's just like a pearl that may or may not be of benefit to you. So questions, I think we've kind of addressed this. So I was talking to Jennifer the other day, again, about, you know, in LA, we have Medi-Cal, and again, that can be challenged for you know, patients getting access. Even when I fill out the forms, I'm the one that does that for the PARP inhibitors. You know, everything just takes so long, and there's high copays and everything. And Jennifer looked at me and she goes, well, everybody in Massachusetts has healthcare. And it's like, oh my gosh, I forgot about that. So every state is different.
Not in Texas. We have the highest uninsured population
exactly.
in this country.
So I think, you know, if we do have, you know, a social worker or case manager or that authorization team, and not everybody does, to find out what is the best route for your patient with these copays, again, to that financial toxicity. So I think going to our companies, I think it's very, the companies that make these medications for the copay assistance, and then really advocating for your patients as well. So talking again about oral adherence, I was speaking to a patient yesterday who told me that she overslept and she didn't take her medicines, blah, 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 blah. So we were talking about what works for her. Now, I will always set an alarm on my phone. Now, she has a smartphone. She goes, no, I don't ever put any alerts on my phone. I said, well, what works for you? And she says, writing it down. And I said, well, that's fine, but you need to put that calendar in your bathroom, in your kitchen, in your bedroom. Because if you only have it in one place, you may forget. So just talking to patients what worked for them. Some people, I think your co-speaker yesterday was talking about writing it down on the calendar. Some people will use pill boxes, but just what are some tips for reminding your patients? Now, again, polypharmacy. If your patient's taking BID, but they're taking several other medicines, and I think about like thyroid medications where they have to be on an empty stomach. Well, it's time to take my olaparib, but I have my Synthroid, and I'm trying to manage when to take that. But then I want to mitigate nausea, so I'm going to take my nausea medicine. So when, you know, what time do I take everything? And just helping your patients, especially the first 4 to 8 weeks when they are more at risk for side effects and they're taking prophylactic medicines to prevent those. How do we remind patients of that? And do they have caregivers that potentially could remind them?
I have also a comment about that. I think that's something that where if you've got a patient that has polypharmacy, that's where sometimes utilizing niraparib that's only once daily and also has a little bit less of the drug-drug interactions. It has less involvement in the CYP metabolism pathway, and that's way pharmacology, way more than I know anymore. But the bottom line is it doesn't seem to interact with as many medications, right. So that sometimes can be a reason to use something like that for the simplicity and for you know the safety of it, right? We often try to get involved with geriatricians. Like I think that's a growing population of physicians that I'm very grateful for because they can really they take kind of a holistic view of the number of medications a patient has accumulated during her lifetime or his lifetime, I guess, and you know get to the point where they're on like 14, 15 different things and really having somebody look through and figure that out. That's I don't know any of that anymore, so I don't do that, but getting them to somebody where maybe they can start thinning out some of the things they're on can also be really helpful to make sure they're focusing on the things that are really critical for their healthcare needs right now.
Yeah, absolutely. Just to add to that, I was doing a med reconciliation the other day with a patient, and we took off like 6 of her medications. I mean, and I think that's one thing that gets overlooked a lot. You know, they come in visit after visit and things just keep building up. And so sometimes it's good just to go in, clean house, and start fresh, but it's hard. They are, a lot of them are on a lot of meds.
Thank you for that. That was really helpful. And I think you're right. Patients are just taking these medicines because they were prescribed at some time in their life. And it's like, well, do you really still need
They're
these?
like, well, you
and
prescribed
not to mention
that.
that.
Yeah, but that, that was then. This is now.
And the cost associated with those medicines that are constantly, there's automatic refills too. And so I have to go pick this up. So, I'm supposed to be on it. The pharmacist refilled it. So addressing healthcare disparities, and I think communication is key. And I think, again, partnering. So our patient, we want them to partner with us. I want them to call me, and I'm the codependent one, they can text me, but my chart, communication if they have access to email. So I want them to communicate with them their needs, and also try to find something out. When I was at nursing school, 100 years ago, number one rule was we could not get emotionally involved with our patient, and they weren't supposed to know anything about us. Well, if I'm taking care of this patient from time of diagnosis to end of life, and it could be 10 years or longer if we're lucky, these patients do know something about me, and we're professional buddies. I'm not going to invite them over for dinner and vice versa, but they care about me. And I obviously very much care about them. So I need to know what works for them. And if there's something that they're dissatisfied with, I want them to tell us that. And interesting is, we talk about, disparities, and it's been reported that patients feel better when their practitioner looks more like them. Well, I can't necessarily change that, but I can ask them about their culture and their viewpoint and their values so that I can get a better understanding. We can get an understanding what works for them and what is important to them. I also want to know about their lifestyle. Whom do they live with? Whom are they taking care of? We know that patients are taking care of their elderly patients. They're taking care of children. Children are taking care of them. They may have, I have numerous patients that their partner is also ill with cancer or some other chronic illness. So the burdens of that. And there's just so much that our patients are going through, not just the day-to-day of what we're dealing with. So I think really communicating with our patients, seeing how we can help them.
And I just want to make a comment, because you'll see the third bullet there says, minimizing healthcare bias. I think, there was often this idea that, oh, well, this patient's non-compliant, this patient's not coming in, and she's not prioritizing her healthcare. But if you explore those very things that Paula was just saying, like, yes, she wants to come, but she has no ride on Mondays and Tuesdays, and she takes care of her, grandmother on this day. And she's too
proud to tell you.
And she doesn't want to tell you. So really making sure you're digging in on those things and understanding, well, what's the reason why you're concerned about this treatment, or what's the reason why you can't make it, and really trying to understand where they're at really can go a long way, because then hopefully you can support or at least express understanding and then try to work around, okay, well, Wednesdays are best. Okay, let's figure out how to make that work. So I feel like that's a huge piece. And, and as Paula said, there's a huge push to make sure that underrepresented minorities are reflected in the workforce. But in the meantime, when, like she said, we can't change who we are. So understanding who's in front of you and how you can address the challenges they're facing is critical.
And expanding on that, talking about clinical trials that totally underrepresented with minorities. And that's one of the reasons that we see worse outcomes, because they may not be in clinical trials. And why is that? And I was saying, it was during COVID when people were not wanting to get vaccines because they didn't trust. And that was huge to me. And I heard that just, here and there. But there's a huge population that does not trust the healthcare community. And it's like, why is that? So if you, I would say dumb it down, so there it is, a terrible word. But talking to people, I used to work in clinical trials, and I remember explaining to patients that we wanted them to enroll. And I think about even what Dr. Weston was presenting today with the patients in the maintenance setting. They were on active drug or placebo. And patients think, oh my God, you're going to give me a placebo? Well, if you have active cancer, we're not giving you a placebo. That would be totally unethical. But we do know, 70 years ago that was happening. But today that would be unethical. But when we offer them a standard of care with or without a new drug versus standard of care with a placebo, they're still getting standard of care. And I think explaining that, and sometimes it's like, I already told you this 3 times, why aren't you getting it? Well, they've never been, I don't say that out loud, but in my head I'm thinking that, because they've never been exposed to hearing about a clinical trial design. All they know is, I don't trust you, and you're gonna give me something or not give me something when I wanna get better. So I think, what is the barrier? And I think that's the thing, is that communication.
I mean, there's a huge history of people not undergoing appropriate informed consent, right? And we've made progress.
It's
still a problem, but I mean, that long-term history is ingrained. And so I think what a lot of the studies are trying to do now is meet everyone where they are, bring in people from the community, people that are trusted, to understand, okay, why are we doing this study? How might it benefit you? Right? And how might you get benefit from this? And these are the risks, and I want you to understand them, and then you make the decision. But we have a long, long way to go, because it also affects how generalizable our trial results are, right? If we have a trial population that's all white, that's not a generalizable trial population. So trying to make sure people get access to the best drugs, but that they also feel confident in their provider, that their provider is picking the right thing for them and is not experimenting on them, right? I mean, that's the bottom line. And so we still have a long way to go there, but there is a lot of research and work going on in that space. So hopefully.
But I'm glad we're having the discussion and being more aware of it. And what bothers people that we might necessarily just overlook. So I think, again, having that conversation is really, really important.
Thank you for attending this edition of CE Conversations. We hope it has been impactful for your clinical practice and, most importantly, for the patients you serve. Please proceed to the link in the show notes to complete the post-test and activity evaluation to claim your CE credit.